Okay, so we're in chapter 8, part 2, part B. We're going to be covering the topic of arrhythmia, which is, if we talk about signs and symptoms in a patient, nothing is a more distinct sign. Sometimes symptoms, sometimes patients can notice it, but there's never a more distinctive sign for onset of pathology than an irregular heartbeat. Even in a person who's relatively healthy, if they have an irregular heartbeat or an arrhythmia of some kind, physicians tend to watch that very, very closely to see if it changes. It can actually increase the risk for certain types of disorders down the line, so they tend to watch it very closely. So we're going to get into a little bit of causality, what drives arrhythmias, and then how we go about treating it.
Moving on to the other part of Chapter 8, which are the anti-arrhythmics. These are drugs that are designed to restore and prevent arrhythmias in the heart, which can be a major source of fatality in patients. On a personal note, both of my mother's parents, my grandfather and my grandmother on my mother's side, both died of spontaneous arrhythmias. I have a suspicion that my one of my great grandfathers died of this as well. So it happens quite frequently, and so it's a very, very important topic, and we want to talk about how we prevent arrhythmias from occurring. Another warning here. The issue here is, again, we can go way, way down this rabbit hole. We can go so far down that we can lose ourselves. And so we want to be very, very careful. And I'm going to try to tread lightly here. Again, look to the book, but also see where I'm emphasizing. I'm going to try to summarize some of this stuff because, again, the book does get pretty technical. When you're dealing with patients and heart conditions, the more you know, the better decisions you can make. And I will always recommend that you learn as much as possible. But again, for the purposes of this class, we're going to try to dial it down a little bit to what I think is truly important. When we're talking about arrhythmias, and we actually can talk about this in normal rhythms as well. It's not that we only talk arrhythmias this way. The two things that we deal with when we try to describe arrhythmias, first of all, site of origin, because the site of origin does have consequences that can be predicted, assuming you know where it's beginning. So we have things like atrial fibrillation, or so forth, or AV node, or ventricles, things like an AV node block, Mobus 2 kind of thing, Mobus 3, that sort of thing. Ventricles, we see arrhythmias coming out of there, pre-ventricular contractions. Things like the bundle branches. If you see a bundle branch block, you see a double spiked QRS rhythm. But then secondly, so site of origin is one thing, and then effect on the heart rate, effect on the rhythm. For instance, if it's too slow, we would call that bradycardia. If it's too fast, we call that tachycardia. And these are just two examples. There are other things that you will see, like fibrillation and so forth. So again, site of origin, and then the effect on the heart rate and or the electrical conduction in the heart. And so here are some examples of what I'm talking about. So let's say we have a normal lead to rhythm. We call this a normal sinus rhythm because it is starting from the sinoatrial node. We used to call the vena cava a sinus. And so it's right there at the sinoatrial junction. So we talk about a normal sinus rhythm. The rhythm is dictated by the normal pacemaker. Here's atrial fibrillation. So what we're seeing here is you don't see a P wave anymore, and you occasionally can catch a T wave in there. I see a couple here. Notice how it's irregular. What's happening is that the atria is sort of fluttering, firing off things, and occasionally one gets through the AV node and fires off a QRS complex, and that's why you're seeing this irregularity of QRS complexes. Right here, again, we have super fast rhythm. This would be atrial tachycardia. That literally, you can see the P wave and the T waves are almost overlapping. And the number of boxes, we're at 2.5 of the boxes. We're only at 12 millimeters. That is a fast rhythm. It's approaching 180, 190 some rate per minute. That's very, very fast. This right here is ventricular tachycardia. Again, but what you see, the arrhythmia is originating from the ventricles, and again, it's very, very fast. So that's a ventricular tachycardia. So so where it's originating, and then its effect on the heart rate or the rhythm. What's going on in these cells? And this is the fundamental basis of the phenomena, that you have this electrical conductivity through these pathways, if you will, that start from the AV or the sinoatrial node through the AV node and then down through the bundle branches and then the Purkinje fibers. Now there's this other little thing called Bachman's bundle. All that's doing is creating a uniform wave across the atria. In any case, you have this system that's meant to coordinate a wave of depolarization and repolarization, and part of that wave is dictated by the morphology of the cardiac cells themselves. They have these intercalated discs which are both strong and communicating, which allow for movement of ions and charge, a depolarization wave, if you will, across them. So we have the combination of the electrical system along with the morphology and behavior of the cells, creating these rhythms and physical events. I'm guessing you've probably had pretty good cardiac anatomy, and I won't beat this to death. I'm assuming, but if you haven't for some reason, if I'm incorrect in this, again we have the SA node, we have the atria, we have the AV node, the bundle of His, the bundle branches, and the Purkinje fibers. And what we're showing here are the depolarization events in cells found in those areas. So we see this funny current, depolarization, repolarization. So sodium and then calcium and then potassium. That calcium is not only going to depolarize this cell, it's going to spread into the atria and trigger an atrial depolarization. That depolarization, this is the wave here, again, sodium and then calcium and then potassium. Here's another pacemaker potential, funny current again. This one will beat spontaneously, so if you have a knockout of this guy will fire off spontaneously at a slightly slower rate. Again, we have myocardial action potentials in all of these other areas, which can lead to ventricular rhythms, by the way. So again, you can see the shapes here. It's just showing you the shape of the action potentials in these different areas. When you look at the myocardial action potential, that is to say the depolarization and then the plateau and then the repolarization, cardiologists and cardiac researchers have defined the phases of this action potential. This is not the same, by the way, as the autorhythmic structures like the SA node or the AV node. This is the actual contractile action potential. They've defined it into 5 separate phases. There's a phase 0, which is where you have a rapid sodium mediated depolarization, closing of the sodium channels, opening of calcium. Calcium then rushes in either from outside the cell or from the sarcoplasmic reticulum and sustains this depolarization. This is known as the plateau phase. So phase 1 is the end of the sodium and the onset of calcium. Phase 2 is this plateau phase, primarily mediated by calcium. 3 is the repolarization. That's mostly due to slower levels of potassium channels opening. So these potassium channels finally open and potassium leaves the cell. So the positive charge leaves the cell, and then you're in what's called a resting phase in phase 4. Some of the drugs are defined by where they act in these phases. They have different classes, and in some ways they're sort of going after some of these phases. So just again to restate if it didn't make sense in the last one, this is not phase one. This is actually phase zero. So you have this rapid influx of sodium from outside the cell. You have this little peak here, and then you have this plateau, which is mostly due to calcium. And then you have a repolarization event. So if you were to do the phases like before, it would be phase 0, 1, 2, 3, and then the resting phase, which is 4. A significant refractory period during this time because contraction is going on. That's due to the calcium influx. And the reason we don't want another action potential during this time would be that you could, in theory, generate tetanus, and that's equivalent to asystole. So we have a number of mechanisms designed to prevent the seizing up of the myocardium. Doesn't mean things don't go wrong, though. Part of the strategy or the significant strategy for dealing with arrhythmias in the heart is understanding from whence those arrhythmias arise, a process known as arrhythmogenesis. When you look at arrhythmias in the heart, there are really sort of two areas that are most likely to trigger these things. And one is impulse generation. That is to say, what is triggering the wave of depolarization and contraction. And secondly would be impulse propagation. So if we're starting up in the SA node, that electrical conduit, if you will, the internodal pathways to the AV node and so forth, that propagation of signal. And so the two major categories of arrhythmogenesis are either in how the impulse is generated or how it's propagated across the heart. Now, it's a very, very simple system in concept, but a lot of things can perturb it. Either you have malformations, either at the tissue level, or perhaps even within the cells. You might have issues with membrane proteins, metabolic stress, injury, even all sorts of injuries. Anything that's going to perturb cells is going to potentially affect their ability to conduct or initiate depolarization and contraction. Autonomic state, you might initiate arrhythmias due to sympathetic stimulation causing the heart to beat too fast or that sort of a thing, inflammation, stretch, and so forth. These things all contribute to things like the ability of the cells to excite, to depolarize. Myocardial heterogeneity, what that means, or heterogeneity, I should say, means that maybe some of the cells are no longer functioning properly, and so the propagation, if you will, is not correct through that tissue. Conduction, that can be through the nodes or through the fibers that we talk about, and or repolarization. And all of these things can contribute one way or another. Conduction, it's a two-way street. Conduction can lead to additional metabolic stress or inflammation. Myocardial heterogeneity can also lead to these things as well. So there's sort of a two-way street with a couple of these things. But then the clinical events, again, this idea that generation and propagation are the issue, and that can lead to arrhythmia, which may lead to further heterogeneity, et cetera, et cetera. So these things can be vicious cycles. Sort of breaking down some of the things that are more common when we talk about generation and propagation may be that the tissue has changed its ability to depolarize. Like for instance, if the SA node, for whatever reason, does not depolarize properly, you might see a slow heartbeat, whereas the gray would be the normal and then the blue would be slower. Or the opposite, you might get increased depolarization leading to a more rapid heartbeat. There is a phenomenon known as reentry. If an impulse isn't being conducted correctly through the heart, you may end up where the rhythm will sort of circle around into undepolarized tissue. Like for instance, normally it's supposed to spread this way and spread this way, but something happens here and we get a block of this spread, and so what happens is we end up with a reentry, and then it begins to cycle sort of like this. It's a bit more complicated than we really want to get into, but reentry is a common mechanism of incorrect impulse generation and or propagation. We can get what are known as triggered activity, where we get an after depolarization. This is sort of a close cousin of reentry, and what you get is this sort of depolarization that can trigger a systole, a tetanus-like event. It shouldn't happen. We're supposed to have a refractory period, but if we have issues with the biology of the myocardium, then these tetanus-like issues may actually be possible. And delayed after depolarizations, that is to say, we would normally have another depolarization and action potential, but instead we get this sort of false, misfire, if you will, and so you don't get a beat where you should. And so these are, you should be able to recognize from a list of possibilities. And again, where do we see reentries? We can see reentries, what we call local reentries, like in the case of the left atrium, or we can see a more global reentry originating from the ventricles. So what we see going on here is we see a spread. It's, for whatever reason, it gets blocked here, and so we somehow get a second depolarization that can then swing around and re-enter. Again, just examples of what's possible. And we're not going to be diagnosing these things, but you want to understand the realm of possibility. Here's a very, very common disorder known as atrial fibrillation. Under normal circumstances, we initiate a depolarization event in the SA node, the sinoatrial node, and it spreads down through the atrium or across over into the left atrium. What we have with atrial fibrillation can be either a combination of reentry, or you get inappropriate automaticity from a different area that's triggering multiple depolarizations that are interfering with each other. So on normal electrocardiogram, nice and regular, nice regulated rhythm. Atrial fibrillation, we see this fluttering, and you see a loss of P wave. Now you might see a T wave in here somewhere, but the real thing is that you have this fluttering of the atrium that's covering up a lot of the lower part of the rhythm. And occasionally one of those depolarizations gets to the AV node, gets through the AV node and triggers ventricular contraction, but you can see that it's highly irregular. And that's one of the dangers of atrial fibrillation, is that you have this irregular heartbeat, which can lead to formation of clots or damage of the myocardial wall or the valves. Ventricular tachycardia, again, another arrhythmia that is not, I wouldn't say it's common, but it is something that we see when you see the onset of a cardiac crisis, because now we no longer have a normal ventricular squeeze, which is incumbent for circulating blood. So this is a life-threatening arrhythmia. The person will probably die if something isn't done. What's going on in this situation is somehow we're getting a re-entry occurring in the ventricles. That's why it's so rapid and it's ventricular oriented. So we're getting this re-entry going on in, oftentimes it's originating in the left ventricular wall that just keeps reinitiating ventricular contractions to the point where you may be blocking the normal depolarization through the AV node, because what you have is this sort of backwards conduction going on. And this is one of the reasons why we would give this person cardioversion. We would shock this patient in order to eliminate this reentry phenomenon that we're seeing here in the ventricles, leading to disordered contraction. So we shock the heart. It causes a brief pause. It sort of induces an artificial refractory period, and by the time it recovers, then the sinoatrial node can resume its normal pacemaker activity. When it comes to the different classifications of antiarrhythmic drugs, they sort of line up with the different phases of the myocardial action potential. And this was originally designed in the late 60s, the von Williams-Singh classification. The main strategy for most of these drugs is to get after something in the action potential to either to adjust the kinetics and the duration of the action potential. Depending on the status of the heart, you may want to go after one area or another. So let's start with the class 1 drugs. These are sodium channel blockers, and ironically enough, they work in phase 0. So sodium is causing this relatively rapid depolarization, and if you slow down these sodium channels, rather than being this sort of near vertical line, what you'll see is that it will slope out to the right. That's because this x-axis is actually time. So millivolts is in the y-axis over time. So if you slow these down, you don't want to stop them. That would lead to asystole. The heart would stop altogether. And that's a very tangible risk in some cases. In any case, you're going to see it arc a little more to the right. It's going to be a little more angled because it's taking more time to get from A to B. So you would see it in phase 1. And so we see these different kinds of drugs, lignocaine and flecainide and so forth. And what they're doing is they're just slowing down the kinetics of sodium influx. Class 2 is what are known as the beta blockers, the beta adrenoreceptor antagonists. And you will see them because they're the LOLs, the LOLs, atenolol and sotalol and so forth. And what they're doing is they're actually working in what we would call phase 4. And it may be that they're not working in the myocardial tissue at all. What they're doing is there are a lot of beta receptors on the autorhythmic tissue. Certainly you can manage strength of contraction, so I'll kind of qualify what I'm saying here. But the beta receptors will also modulate rate of the funny current in the autorhythmic cells. So if you block those beta blockers, you no longer can effectively stimulate the heart with a sympathetic stimulus, and that's going to slow the heart down. It will prevent the heart from accelerating as much as it might. And so that's why they say it's phase 4, because it's in the resting phase of the myocardial action potential. But what it's doing is it's basically slowing down primarily the rate of contraction or the rate of excitation from the autorhythmic tissues, and it would probably reduce the strength of contraction in the myocardium, maybe not quite so much calcium, something like that. But that's a little bit unclear. It's more about rate when it comes to these antagonists. Class 3 drugs, what they work on is they will prolong the action potential. And so what's going to happen is you're going to have this prolonged shoulder phase, if you will, or you might see it slope a little bit. In any case, what's going on is the calcium sticks around inside the cells longer, takes a little longer for potassium to kick in. What you're doing is you're prolonging the refractory period. So if there's some other signal coming in here trying to get this thing to depolarize, if you're in the refractory period, you're not going to initiate another action potential, which could help prevent reentry. Reentry is where you have this inappropriate re-stimulation. And so, some beta blockers might work on this. Amiodarone is one of the front line drugs for that. And then finally, we have the class 4, which sort of also works in phase 2 as well. Class 4 are the calcium channel antagonists. And so we're going to slow the calcium influx down. You will see a weaker contraction, again, maybe a slower contraction, with the idea of resting the heart, slowing it down, trying to reestablish regular order in the myocardium. So the therapeutic concerns for patients who are on these medications, these are things that you can really take home with you. These drugs are powerful, and they do need to be treated with care, both on the side of the caregiver, the prescribing authority, as well as any part of the healthcare team, including the patient themselves. One of the things that can happen is that because you are slowing the heart down, because you are inhibiting myocardial processes, you may end up inducing what we call cardiac insufficiency. That is to say, the cardiac output is not sufficient to meet metabolic need. That may arise in the form of exercise intolerance, or sort of a chronic low-grade insufficiency, if you will. They're just tired all the time. They just can't get around as well as they would like. Or it can be the opposite. It can be sudden onset, acute, and life-threatening. Like for instance, let's say for for example's sake that you see a drug cause too much suppression of one of the pathways. The sustaining of contraction is too long, or the influx of sodium takes too long. You might see this onset. That antiarrhythmic drugs themselves can trigger arrhythmias. Let me just give you another example. I'm going to illustrate up here on the right. Let's say we have a pacemaker that's firing from the SA node at 75 to 80 beats per minute. So we've got this nice signal coming down. That will mask autorhythmicity in other parts of the heart. If we lose the SA node, the AV node will fire off, albeit at a slower rate. And if we lose connection between the atria and the ventricles, what we call a block, the ventricles will fire spontaneously, albeit at a much slower rate, somewhere around 25 beats per minute. So let's say there's a problem with the myocardial wall in the ventricles, and it's not 25, it's more like 60. So if our SA node's firing off at 75 or 80, it would mask that. But if we slow this guy down to something below 60, we might begin to see an issue, because now this guy is starting to go faster than what this guy is. That's what we're talking about. That the antiarrhythmics may uncover other abnormalities in the heart that then manifest as arrhythmias. 3 and 4 are very, very similar, so I'm going to bring them both together. That both, and this is the teamwork side of it. You want to monitor pulse rate and the rhythm regularly. They should have a baseline electrocardiogram with them almost at all times in case something goes wrong and you can begin to see what's going on. You want to monitor pulse, just check pulse from time to time, particularly if the patient is non-ambulatory or unconscious. And again, they should watch themselves. They need to be careful because their heart is damaged, and we don't want to initiate any new problems on top of the ones we're already dealing with. And then lastly, if the patients are doing an exercise, and we start to see some arrhythmias, we should never ever abruptly end the exercise. That may lead to a sudden onset life-threatening situation. We do want to get them into care and monitoring and so forth, but you don't want to just quickly cessate unless you absolutely have to. If they're doing exercise and they're starting to feel something wrong, slow them down, but kind of keep them moving a little bit and get them to where somebody can deal with the issue. But the take home here is watch these patients, try to educate them on the possibilities with the drugs that they're taking, and keep them on a good routine of monitoring, assessing, and self-care. This concludes Chapter 8. Thank you for your time. Again, look to how I have discussed some of the issues. These things can get a little technical, particularly when you're talking about the arrhythmias a little bit. Make sure that you focus on what we've discussed, and all the best. If you have any questions, by all means, reach out to me. But you guys are going to be on the front line of this. This is a very, very, very big thing, and it will continue to be a big thing probably for all of our lifetimes. This high risk, which means it's much more likely that even outside of a professional, you yourself may be one of these patients. So good luck, thank you, and I will talk to you soon.